Okay, Assalamualaikum and good afternoon. I find it very nerve-wracking to be the closing speaker of the day. I hope that all of you are still awake and more than just alive. Okay, so the final talk will be about peripheral nerve injuries. Probably the rarest thing to be on the mind, but also potentially the most catastrophic for your patients. I do not have any disclaimer other than the fact that I've had one suspected case of a peripheral nerve injury, but after thorough rechecking of the history and the clinical case note and the nerve conduction study, it turned out to be procedure related and not related to regional anesthesia. So this is the outline. I'll just skip it. But for all of us, we need to remember there are many important complications of regional anesthesia. And one of them, you may not think of it as much, but one of the major complications is wrong-sided blocks, which in any hospital quality issue, should be a never event, like your wrong blood transfusions. And then you have your nerve injuries, which today we're going to talk about peripheral nerve injuries. And then anaphylaxis, which is relatively rare with preservative-free amides, and as well as LAS. And I'm sure you've had other lectures. The first lecture of the day probably took away 50% of my talk. But on the right is an example of a protocol for management of LAS with intralipid. Okay, you cannot talk about you cannot discuss peripheral nerve injuries without going back to the microarchitecture of the nerve. And we know that nerves consist of axons, which are covered by a myelin sheath, and then these axons will be bundled together into fascicles, and then these fascicles will be covered by a perineurium. So the perineurium is relatively tough and is relatively is a relative chemical barrier, and therefore it maintains a good internal homeostasis environment for the nerve bundles. And then all these fascicles will be bundled together into a nerve, and they are covered by an epineural cover. And this epineural cover is relatively loose. There's chemicals can pass through, and sometimes you have nerves which are also covered by another fascial layer. And an example of this is the sciatic nerve. One of the previous speakers has already talked about the Bloca sheath. So the sciatic nerve, when you talk about it in the true sense, it is actually just two nerves in one, which is the tibial nerve and the common peroneal nerve. There are two nerves bundled into one sciatic nerve, and the sciatic nerve itself is covered by a special paraneural sheath called the Bloca sheath. So when we talk about peripheral nerve blocks, basically nobody talks about peripheral nerve blocks as being an injection into the nerve. All peripheral nerve blocks are generally thought of as being perineural. And sometimes we find that peripheral nerve blocks can work even without the LA deposition being exactly beside the nerve. And because at the end of the day, we have to go back as to how peripheral nerve blocks work. So when we deposit the LA at beside the epineurium, so the LA will diffuse through the epineurium barrier, which is relatively permeable. And then that high concentration of LA will slowly diffuse through the perineurium, which is a relative barrier, and from then it will enter into the nerve and exert its effect on the sodium-gated channels. So another thing to keep in mind is that even though fascia is relatively tough, it is not completely impermeable to LA. And we find this in one of the studies which is done way back in 2011, where Spence and his colleagues actually experimented doing an interscaling block. In one method, doing it beside the fascia without piercing the fascia that goes into the interscaling compartment. And one technique, like a true interscaling technique, where they pierce the fascia and deposit the LA beside the C5, C6 nerve roots. And they found that the block rates were the same success rates. And same onset of action. So that's about when you talk about placing your LA at a perineural location. But then what about intraneural? So we are all afraid about peripheral nerve injuries, and then so one of the things we talk about is intraneural injections. And then the question becomes is intraneural injection in itself is it harmful? So when we talk about peripheral nerve blocks, we all want our needle to be away from the nerve. We want our LA to be surrounding the nerve. So basically a perineural injection, and that's what we want. But is intraneural always harmful in itself? So this is one of the studies by Bigelsen, quite a controversial study in 2006, where they follow up patients experiencing axillary nerve blocks, and some of these injections were all intraneural, and you can see at the second picture there, you can see that the needle is clearly within the nerve, and then after the injection, the nerve becomes swollen, and after removal of the needle, you see that the nerve remains swollen with a halo around the nerve. So in this particular prospective study, there were 26 patients, 104 injections, of which the majority were intraneural, and none of the patients developed any neurological deficits. And then the question becomes, why? So to understand this question, we need to look at the multifactorial nature of why we do not get peripheral nerve injuries, or why we do get peripheral nerve injuries. And one of the things that we have to look into is actually the needle design. So when we do peripheral nerve blocks, almost exclusively all of them are done with short bevel needles. And the reason is that long bevel needles, they readily cut through the tissue, and therefore you have a higher risk of actually accidentally penetrating the nerves. And then that might make you question back again. So I do all these wrist blocks blindly, I do all these ring blocks blindly, I do all these ankle blocks blindly, but either we do not follow up, or we do not see that there's a significant rate of nerve injuries despite the use of these long beveled needles, especially with these small nerves. But then again, when we talk about most of the nerve blocks that we do all of them with short bevel needles. And these short bevel needles have greater resistance when you want to penetrate tissues, and therefore you appreciate the clicking and the popping of the fascial penetration. But on the other hand, if you accidentally penetrate the nerve because of the relatively blunt nature of the needle, you will get greater histological damage to the nerve. So another thing to keep in mind is everything will follow a path of least resistance. So we know, like I mentioned earlier when we talk about the nerve microarchitecture, so the epineurium compartment is relatively loose while the perineurium is relatively tough. So if you accidentally puncture the nerve, more often than not, your needle will actually be in the interfascicular space rather than piercing the perineurium and being intrafascicular. So another thing to keep in mind is looking back at you can't move away from the microarchitecture of the nerve. So when you look at the nerve root, you see that there's a much higher density of fascicles as compared to connective tissue within the nerve itself. And you see here very clearly in the interscalene view, when you look at the C5 and C6 nerve root, they are all very clearly densely stained with fascicles. And that's the reason why people postulate that one of the reasons why interscalene nerve blocks are associated with higher risk of injury is because of this. Because when you move more peripherally, so from the interscalene to the supraclavicular and the infraclavicular regions, you see that there's a reduced density of the fascicles, and there's a greater amount of connective tissue. So if you accidentally puncture the nerve, you will hopefully be within the connective tissue rather than into the fascicle. And you see this again in the sciatic nerve, where again you see that the sciatic nerve is basically two nerves in one. And you see as you go from proximal to distal, as the sciatic nerve diverges into the common peroneal as well the tibial nerve, you see that there is a much greater concentration of connective tissue as compared to the fascicles. Another highlight here is that if you look at the tibial nerve versus the common peroneal nerve, you also see that the tibial nerve has a lesser concentration of fascicle compared to the common peroneal nerve. And this is probably the reason why when you talk about in terms of the perioperative setting, common peroneal nerves are much more common than the tibial nerve. So how to deal with PNI? I think the most important question to deal with it is actually to make considerations so that you do not have it happen in the first place. So there are many stages to think about: pre, during the block, as well as after the block. And along with all the absolute contraindications like patient refusal or local infection, there are other things to consider. So one of the important things is, in the ED setting, you need to know which trauma scenarios are associated with nerve injuries. And does the patient have a pre-existing neuropathy? And like one of the other speakers have mentioned, one of their contraindications is an uncooperative patient. So you must think about, is there anything that any other distracting injuries that prevent you from having a proper neurological assessment before you do your block. And you must also think about the issue of informed consent. So that's why I think it's reasonable if you cannot have a cooperative patient, you may exclude them from offering them regional anesthesia. But at the same time, you know that severe pain is not good for overall patient care. So I can't answer this question as an anesthesiologist. This is something that in the ED setting, you have to consider in your local setup and how you're going to maneuver about this particular scenario. So there are some trauma scenarios which are associated with nerve injuries you have to keep in mind. So, for example, if you have a shoulder dislocation, you want to do a CMR, you need to check for the common nerve injuries. And if you have a mid-shaft humerus fracture, you have to check for a radial nerve injury. In fact, for us anesthesiologists, a lot of time we may not offer regional anesthesia for mid-shaft humerus fractures because the incidence of radial nerve injury is extremely high. So you have to be mindful of this. So you must have an adequate review of the neurological function before you do your block. So, and you must inform patients that at the end of the day, when you look at the incidence of nerve injury, the most common will always be the trauma itself, second the procedure, second the regional anesthesia technique, and then you allow the patient to have an informed consent. I know this is not related to the ED setting, but in the operating theatre, various types of surgeries are associated with nerve injuries. And this is despite whether you give regional anesthesia or not. So this again highlights the fact that nerve injuries are common even without doing blocks. You can have femoral nerve injury after laparotomies because of injury retraction to the femoral nerve. You can have injuries to the brachial plexus after sternotomy from sternal retraction. So these are things that you must be mindful of. Okay. And then what about pre-existing neuropathy? The first speaker has already spoken about the double crush theory. And you must keep in mind that in patients with pre-existing neuropathy, there's a concern that if you give them a second hit, then they may suffer from a more significant permanent injury like denervation. Okay, so, but how do you go about? Actually, when looking into the literature, you will find that nobody has a concrete way of managing these kind of scenarios. Everything is a case-to-case basis. You have to consider the risk-benefit analysis whether you want to do a block or not. So, for example, and this can be very readily seen in the operating theatre, where you see your septic patients with multiple comorbidities. They require an amputation, and we will still offer them regional anesthesia because in many cases, regional anesthesia is still more preferable to GA. So everything must be a case-by-case basis. And then another thing to keep in mind is that it is known that in patients with diabetic neuropathy that the LA requirements for block is much less. So even in my own personal practice, in the past, I used to give 20 mils of 0.5% ropivacaine for all my sciatic nerve blocks. But nowadays, I find that if I can get a good LA placement, I find that even 15 mils is already enough for these kind of patients. So you have to consider adjustment in your LA dose. And I will talk a bit more about this later. So block selection is the key. So again, you must remember all blocks are perineural. Intraneural placement is never necessary for block efficacy. And you must always consider the actual aim of your block. Is it anesthesia or analgesia? So if it's an analgesic block, do you really need to give such a high dose? Do you really need to give such exacting LA location for your block efficacy? Maybe not, depending on the proper skill of your block. Okay. So, and let's say if you do not require anesthesia, you only require analgesia, then why not just do a fascial plane block? Because if you do a fascial plane block, even though you have a higher risk of LAS, you obviate the possible risk of perineural, the risk of peripheral nerve injury. So what about during the block? Obviously, during the block, you must have good sonographic skills. This will take time, this will take practice. And I think one of the easiest ways to practice this is by starting to do in-plane procedures even now. So I think we in Malaysia, we tend to do a lot of out-of-plane techniques, especially for our vascular access procedures. I think you can start practicing in-plane techniques for your vascular access, because that will translate well to most of the rigid anesthesia techniques which are done as an in-plane manner. And then the reason why is because you must always ask yourself, is the needle exactly where it is? So whenever a superior asks you, where is the needle tip? Where is the needle tip? Are you sure that that's where the needle tip? Because you will only see where the ultrasound beam transects. So, and because you need to remember that at the end of the day, even though we give a lot of LA, only a small amount enters the nerve, and actually that's the one that exerts the effect. So if you misplace your nerve and enters the nerve, then the LA dose is potentially neurotoxic. Okay, so this is by one of the gurus of rigid anesthesia, Sui, so where he wanted to design a training modality to practice in-plane needling technique. And you can clearly see, okay, not really from the first picture, but the second picture on the right, where is the beam, the needle is actually on the right side, not the left side. So if you can see on the right side, it's only a circle there, because the beam only touches the tip of the needle. So only with proper needling technique at the lower left picture here, that you see that the whole needle tip and the shaft is visible. So this highlights the fact that you must have good in-plane needling technique, and especially with good sonographic needles, there is almost no excuse for proceduralists to not be able to visualize the needle during the block procedure. So some blocks like the interscalene, again, do not require LA deposition into the fascial space itself. So you have some safety margin to be away from the nerves. And then other safety measures include hydrolocation to aid the technique. So let's say if you do not see the needle tip for whatever reason, you can use hydrolocation to see at which particular area you are. And then always, this is one of the interesting things, is to approach structures in a tangential and not a direct manner. So this has been demonstrated by Symposium in 2016. So where they compared two approaches to the nerve, one as a direct perpendicular technique and one in a tangential technique. So the premise here is that by approaching in a tangential technique, as you penetrate the fascia compartment into the nerve, so you will push away the nerve by rolling it away, and you avoid penetration as compared to a direct perpendicular technique where you have to be very gentle to not overshoot your needle entry. And this was highlighted in the histological studies of these cadavers. So where on the left is a direct technique, while on the right is a tangential technique. So as you can see on the left with the direct perpendicular technique, the dye is actually stained into the epineurium compartment, whereas on the right, the dye remains at the outside of the nerve. But even here, you see that the needle actually doesn't penetrate the perineurium, and the fascicles are spared. So what about monitoring? Let me just have a raise of hand. Anybody of you still use nerve stimulator? Any one of you use injection pressure monitoring? I think it's very clear that the issue of monitoring is contentious and controversial, and many people have absolute views. But I think what's important is to understand that there are nuances to the discussion, and we need to remember that no modality is perfect. So when we move away in the history sense from peripheral nerve stimulator guided RA to ultrasound guided RA, there is no reduction in the nerve injury rates. What has changed is the increase in efficacy and the ability to reduce the dose, but not in terms of the already low rate of peripheral nerve injuries. And one of the things that makes it difficult for anyone to make studies regarding peripheral nerve injury is that the rate is already too low to begin with. So as if you know anything about statistics, if the incidence is already too low, it's very difficult to design a study where you have enough sample size for it to have enough power to say that one recommendation is better than the other. So, and then you have some people saying, okay, if that's the case, why don't we just do triple monitoring? I think the jury is still out as to whether it really improves outcomes and whether it really warrants to be used, because you can have false positive, you can have false negative, and I'll talk about this. So we have moved away from peripheral nerve stimulator-based RA to ultrasound. So we know that ultrasound is not good enough for you to see the microarchitecture of the nerves. So you can see where the nerves are, but you do not see which part of the nerve. You do not know which is epineurium, endoneurium. You can't see all that. And the skills of the procedures play a big role in where the needle goes. So if the operator is not as skilled, not as experienced, the needle may be accidentally punctured into the nerve, and it will happen. So in the past, one of the ways to see whether you are at the nerve is a paresthesia technique. And we have now moved away from using paresthesia to locate the nerve and now move towards it being an indicator of potential harm. But at the end of the day, paresthesia itself is not a sensitive indicator. There are many studies that have shown that intraneural placement of the needle does not result in paresthesia in all patients. But it is quite specific. So if you see paresthesia, stop and think, maybe you need to pull out your needle. But there are many instances where the needle goes into the nerve, but maybe you will not touch a fascicle, patient will not feel anything. And if you have a patient with pre-existing neuropathy, it's going to be even less sensitive. So that makes people, the fact that people want to use paresthesia means that's why most people will avoid doing blocks under GA. But then again, when looking back at the history of pediatric radial anesthesia, almost all these techniques are done under kids. And the rates of nerve injury is not higher than that of adults, where there's a lot of weight-related RA. And this itself has been acknowledged by the APSF, the Anesthesia Patient Safety Foundation, where they themselves have acknowledged that there is no proof that awake RA confers benefit versus sedated or GA RA. So what about the popular peripheral nerve stimulator? So it is specific. So if you can stimulate nerve, you see a response, it's definitely there, but it's definitely not sensitive. And there are varying recommendations. Some say 0.5, some say 0.2, some say you use different level for different nerves. And this is quite confusing for practitioners to use as a guide as to what level to use. Are you going to use it to see whether you are near the nerve? Are you going to use it whether you are potentially in the nerve? So it's not a black or white matter that tells what is right or wrong, and therefore the jury is still out as to whether it's really that useful. And I'll say a bit more about it later. Since nobody has ever used injection pressure monitoring, probably you have never even seen the picture of the injection pressure monitor. So there are some models in the market. Some will just show what is the pressure when you inject. Some will have a limiter. So if the pressure becomes high, it will stop the injection. But what's the premise? So the premise is that if you have a needle inside the fascicle, you will have a high intraneural pressure, as compared to if you are between the fascicle or you are outside of the nerve, you have a low injection pressure. So, and the fact that you have low injection pressure will have some element of safety. And most of the recommendation will say that an injection pressure of more than 15 psi is generally not safe. But it is also not, how should I say, it is also not specific. Because let's say if your needle is abutting a tough fascia, you will also have a high injection pressure. It's not, it is just high injection pressure, but it can be from any structure, whether it's from the fascia or whether it's from the perineurium. So this is one of the studies which show that as you remember just now, the microarchitecture of the nerves, so as you go from proximal to distal, the intraneural injection pressure actually gradually goes down. And this reflects the architecture of the nerve. But generally we use 15 psi. So why is it controversial? Because at the end of the day, even when talking about the ASRA guidelines, even they themselves state their language very carefully. It is only as a practice advisory, not as a guideline. And they themselves have acknowledged that that a lot of these of their recommendations are all based on studies which do not have a lot of power. So there's a lot of opinions. So that's why many of you have gone to HKL. We do not use nerve stimulator. We do not use injection pressure monitoring. And in HKL for shoulder surgery, we do interscalene under GA. So wide areas, some people will say, no, all blocks must be under peripheral nerve stimulator. So there's quite a wide schism. But you can see that even the ASRA guidelines, which have been long ago and not really updated after almost a decade, they themselves state their language very carefully as just as a practice advisory. So next, post-RA care. So all the previous speakers have already mentioned all this. You must have clear patient or ward instructions. You must have a mechanism follow-up. And then lastly, we go to the topic, what if peripheral nerve injury occurs? So you must inform the patients about the expectations regarding block recovery. They must always be clear that they might be nerve injury from the underlying condition or the intervention. And all the previous speakers have already shown their examples of how to have a facility for self-reporting, to contact, or their own internal department phone call follow-up. So these are things that you have to consider as part of your local setup. So incidence of PNI itself is quite difficult to define. It is generally rare. Some mild persistent symptoms occur in less than 10% of blocks, and again may not be related to the block anyway. But in any case, a lot of peripheral nerve injuries all resolve within 6 months, and it's very rare that you get peripheral nerve injury. But it's still important because for the patient, it is a devastating complication. So what about our local data? In terms of HSA and HKL, almost 700 over blocks, 0 peripheral nerve injury cases. And the majority of these are all done for pain intervention, followed by CMR. You cannot run away from PNI without going back to the textbook, the Seddon and Sunderland classification of nerve injury. The majority of nerve injuries related to RA will be neuropraxia. Some may be axonomaxis. But if you ever tell me that a patient gets neuromaxis where the nerve is completely severed from a rigid anesthesia technique, I think my jaw will drop to the floor. Okay. So what about the mechanism? This has already been highlighted by the first speaker in the morning. So very obvious, you can have mechanical injury from the needle or the catheter. So direct injury from the device itself, which can result to, or you can have injury from disruption of the perineurium, which then destroys the protective endoneural environment. And then you can also have microhematomas, which can also exert direct injury effect. So what about toxicity-related effects on the nerves? All LAs and most of the agents are all neurotoxic, like steroids. So neurotoxicity is time and concentration dependent, which then highlights again the fact that doses are always generally overdosed. And it's that small amount that enters the nerve that actually exerts the effect. And this highlights the importance of the environment provided by the perineurium. And if you give the patient adrenaline to prolong the block, you know that adrenaline causes vasoconstriction, so delayed drug clearance for the nerves, and then a higher exposure time to potential neurotoxic LA. So what about another factor is ischemia. The nerve supply, the majority will be from the vasa nervorum, which has a lot of anastomosis and is relatively resilient. And you can also have injury to the major vascular supply. But most of the nerves, they do not have a particular nerve supply per se, except for the sciatic nerve, which has a particular feeding artery. Another less well understood mechanism is inflammatory. This is mainly seen in interscalene nerve blocks, where very rarely patients can develop chronic frank nerve palsy because of interscalene nerve blocks. And this is probably postulated to be a inflammatory mediated complication. So this is the RA-UK peripheral nerve block follow-up, initial management of post-op unexpected persistent neurological dysfunction. Okay, it looks very small, never mind. We'll zoom in. Okay, so whenever you do a block, the most important thing is to see is the patient's pain well controlled or not. So if the patient, if you do not suspect anything wrong, and then you just check is the pain well controlled or not. So if the pain is well controlled, then you are well and good. But if your pain is not well controlled despite the block, then you need to consider optimizing your multimodal analgesics, or if there's an element of neuropathic pain, then you may need to consider anti-neuropathics. So this is, okay, well, fine and dandy. So the more important thing is, if you do suspect peripheral nerve injury, the most important thing is to, again, check back the history of the patient. Because a lot of times, we are all human. Sometimes we forget to check the pre-existing deficits, and we find that, doktor, sebenarnya saya daripada dulu lagi ada masalah kebas ni. So if you miss the history and you've only noted it after the block, then you document as such. But if you see any different symptoms, what you need to know is it an urgent or a non-urgent lesion? So how you define this is basically, is there persistent motor-related symptoms? Is the symptom associated with pain, or is the symptoms worsening? So if the symptoms are not really worsening, you again check the neurology of the patient. Is the block related to the nerve block? Because if it's not related to the nerve block, then you need to consider other causes like positional or procedural or the underlying trauma, and then you treat that accordingly. But if it does correlate to the peripheral nerve block, the management is generally conservative. So you reassure the patient and you follow up. It is a possible peripheral nerve injury of a neuropraxia origin. But if it's an urgent lesion, that's where time is a factor. So you must see whether it's related to the nerve block or not. But even then, it is still urgent, because if it's not related to the nerve block, is it compartment syndrome? And if it's compartment syndrome, you still need immediate action. And you will need to refer the patient to the particular physician that's responsible. But let's say if it is related to the peripheral nerve block, and it is an urgent lesion, so you still need to refer accordingly. So you may need a peripheral nerve surgeon review. You may need a neurology consultation. You may need urgent imaging, especially if it's a central neuraxial, which is not the topic for today. So the reason why you may need imaging is because you may need to decompress. For example, with a central neuraxial technique, if you suspect epidural hematoma, the patient may require urgent decompression. Okay, so, okay, I'm on time. So the takeaway, always consider the local setup and your indications. I think this is very clearly highlighted by the sharing session, from the first speaker all the way to the talk before me. Okay, so always consider the local setup and indications. You must have a policy for risk mitigation and your follow-up. So if, let's say, peripheral nerve injury does occur, it's best that you have a policy already in place. So you will need communications with a neurologist. You will need communications with a peripheral nerve surgeon, orthopedic lah, the hand surgeon usually. So you will need communications with a pain specialist, because let's say if the patient develops chronic pain, then they will need a pain physician to coordinate their care for holistic care. So these are my references. Thank you.